So we now go over to posterior segment foreign bodies by Dr. Apoorva. Dr. Apoorva is a young consultant at Joshi Eye Institute. Um, she is also an avid researcher and a very prolific surgeon. Dr. Apoorva, please.
Hello. Yeah. Thank you for the opportunity, sir. Today I'll be talking about erecting posterior segment intraocular foreign bodies. Most of the foreign body cases that we get are because of patients indulging in metal on metal activity in garages or lathe machines. I'm presenting from my laptop.
I request one of the audiovisual people to be there at the podium to get it started.
It's connected. Yes. Is it फॉर्मेट नहीं है ना ये साइड का नहीं जा रहा है ना साइड का नहीं जाएगा एक सेकंड या ठीक है हाँ So pars plana vitrectomy is the standard management by VR surgeons. It can tackle all types of intraocular foreign bodies. It enables precise visualization. It makes surgery controlled and predictable, no matter how unpredictable it may seem on table because of various associated pathologies like retinal detachments, giant retinal tears, endophthalmitis, and sometimes even panophthalmitis. This is a scenario that we can encounter where there is a firm encapsulation of the foreign body by the coats because of an inflammatory reaction. So whenever the media permits, if possible, pre-operatively, even in fact several days before, we can opt to laser around this foreign body and its encapsulation so that during surgery at PVD induction, which again has to be at the margin of this foreign body, it can prevent a tear formation. These can be notoriously attached, very adherent to the coats and can cause iatrogenic tears and a retina that refuses to settle. So if we are doing a preoperative laser, it has to be done several days prior so that the laser has time to act and take up. So this is a video of a retinal tear which has occurred due to the ricochet of the foreign body, and this has to be lasered before the PVD induction. Like I said, at the time of PVD induction, at the border of this tear, the retina can get lifted. So to prevent that, we can do a laser intraoperatively around the margins, and then before PVD induction, we can take care of it. So of course, if the patient has been rendered aphakic in the first stage of the surgery, a limbal route is also preferable because the limbus is much more forgiving than the pars plana, and it can accommodate much larger foreign bodies and especially non-magnetic foreign bodies. Also, you can float it up with PFCL and use an extrusion with high vacuum if it is not coming with any forceps or a magnet. This I am talking about non-magnetic foreign bodies. A buckle or band is up to the surgeon's discretion depending on the support that the base needs, especially if it is inferior retina and inferior vitreous base. Total encirclage with a 240 band or a segmental buckle, a large one like 279 can also be placed. So to make this presentation a little more interesting, I'll be presenting my challenging cases that I've encountered in the past 2 or 3 years. This is the first challenging case. This was a 48-year-old gentleman with history of trauma to the right eye with a metal on metal activity. There was severe pain, redness and swelling. The patient also had intractable vomiting. The vision in the right eye was only PL and the ocular movements were restricted in all gazes. There was proptosis, severe chemosis and a lot of anterior chamber reaction. Now this was the B scan of this patient. We can see that there is a very obvious foreign body with the back shadowing, and it has a very large spike on the A scan as well. And you can see that there is a retinal detachment as well. There are a lot of exudates, and here you can see a T sign. So this is a very infected case, and it is a panophthalmitis, and it has an intraocular foreign body. Now the preoperatively systemic cover was given of antibiotics, painkillers, and the patient was explained very guarded visual prognosis, and the surgery was started. We can see that there is an entry wound through which there is a necrotic retina which has already come out. So I just did cut the retina flush with the sclera. After that, the AC exudates were cleared. The lens was removed, and you can see just behind the lens there is a lot of necrosis, and there was a lot of necrosis, so we cleared that. Now when we go in, there is no view at all. There is a lot of vitreous hemorrhage, some necrotic tissue seen. These lights don't help either. So it will get better in a couple of seconds. So I decided to scrape the cornea and go in, and saw that this was the situation. There was a totally bunched up necrotic retina. I'll just show that again. This is all bare RPE that you can see. And now when I put PFCL inside, the necrotic retina opens up a little, and you can see the prized foreign body right in the center. And I chose to remove all the necrotic retina at the base to reduce the load of inflection. Here is the foreign body that is lying right in the center like some treasure. So since the patient was aphakic, I chose the limbal route, made a clear corneal incision, and under visco, I removed it with a handheld magnet first, and at the limbus used an external magnet and removed this foreign body. So this was a very challenging case with incarcerated retina which was extruded, and we had to cut it flush with the sclera first, then go inside, remove all the exudates, and then find that the retina was having a 360-degree giant retinal tear with necrotic retina. And I couldn't save this eye. I just did an FAE and came out, hoping that at least this patient didn't undergo an evisceration. So the eye was saved. So this was post-op 1 week. A retina photograph could not be obtained because of the haze. But now you can see that he's actually opening his eye, and the movements also have been restored to a large extent. So that was a case of panophthalmitis, GRT, and an intraocular foreign body. This is the second challenging case which I saw in 2021, 3 years ago. This is a 38-year-old man with the trauma to the right eye 10 years prior, uncertain about the mode of injury. He had neglected this eye and had blurred vision since 5 to 6 years. The vision was only hand movements, and there was a posterior subcapsular cataract with posterior synechiae. The ultrasound was done, which showed a total retinal detachment. This patient was posted for right eye synechiolisis, cataract surgery, and RD surgery. Now this was the first surgery that we do. We retina surgeons usually talk in terms of which surgery, first surgery, second surgery, third surgery, because we know we'll go in again. So yeah, that apart. Now you can see that there is a lot of vitreous haze, opacities which we took care of, and then there was this nasal incarceration of the retina. Here you can see that there are retinal folds nasally, and this one here. So I released it from its incarceration, did a thorough base shaving, went in, saw there were chronic folds at the macula, and I managed to attach this retina. Now, after 2 months, the patient had a redetachment with lifted retinectomy edge. Now this time, I had to use iris hooks. I thought I was doing reasonably decent surgery, removing all the membranes meticulously. Lo and behold, at the nasal edge of this retina, at the retinectomy margin, anterior retinectomy flap, there was something shining back at me, glistening, and was horrified to find a human head in the box. Morgan Freeman, I found a intraocular foreign body in this eye. I was as horrified as him. Under this anterior flap, there was a foreign body, and it was hiding under the retinectomy edge. So now if I see this eye, you can see that there's a lot of siderosis, definitely. And that's of course in hindsight. Then we did a 360-degree retinectomy, managed to remove the foreign body as well as attach this retina. But like I said before, it redetached again. This is the third surgery, removed membranes. And this is just to show how aggressive PVR can be in an eye that has had a foreign body which has not been so inert, because siderosis is also inflammatory, and inflammation can be a great setting for PVR and recurrent detachments. So this patient underwent 3 surgeries and probably didn't come back to me because of the poor prognosis. But this is just to show that the foreign body can be hiding under flaps of the retinectomy edge. So now if you look back, this is definitely a siderotic appearance of the retina in the first surgery itself, and we should have suspected a foreign body. So the lesson was to look inside the box and search every nook and cranny of the eye for neglected trauma cases. So this is the third case where I was a little wiser, I think. This boy had a neglected trauma in the left eye for 15 months. Vision was only PL. Fortunately, looked carefully, and on clinical examination itself, there was an IOFB. There was a GRT and open funnel RD. These are telltale signs of siderosis, like KVS sir was showing in his presentation. This is a typical pigmentation spots of ocular siderosis. So you can see that, and you can be sure that you will find an iron foreign body inside. After cataract removal, put an infusion, 3 ports, sparse plana vitrectomy. You can see how siderotic even the vitreous is, how pigmented it is. And you can see this is the foreign body when I did an indented demonstration for the onlookers in the OT as well here. This is the foreign body. And you can see how pale and yellowish brown the retina is. That is also a siderotic retina. Here there is a GRT, and after base shaving and freeing all the GRT edges from adherent vitreous, the foreign body was now tackled. This has probably become demagnetized after a long time in the eye, and I tried using a handheld magnet and removing it till the sclerotomy site, but the external magnet could not manage to remove it. And you can see how pale the vessels are. These are all telltale signs of siderosis. These are all toxic effects of the ions, ferric ions. Now, I've placed the PFCL inside, and again I used a magnet, intraocular magnet, tried with an external magnet, didn't work. Although I can feel the metal on metal, it's just refusing to come out. So I went in with the intraocular magnet, made sure I removed and freed all the vitreous around the foreign body as well as near the base, and then chose to remove this foreign body through the limbus under viscoelastic protection. And then sutured the sclerotomy and the limbus and completed the vitrectomy. You can see that the retina is free from any membranes, and vitreous base shaving has been done meticulously. You can see that it has settled under PFCL, and now it's settling under air as well. The retina looks very good. I have completed the laser. And after that, I inject oil, and the patient is attached so far. So evicting posterior segment intraocular foreign bodies is through pars plana vitrectomy, which has to be thorough with base shaving and checking the subretinal and pars plana areas. You can choose to add a belt or a segmental buckle depending on the need for support by surgeon's discretion. It is a Pandora's box. It can have detachment, multiple tears, GRT, endophthalmitis and panophthalmitis like I showed. And it can be a classic case for recurrent detachments. Thank you so much.
Thank you, Dr. Apoorva, for that wonderful compilation of difficult cases, especially the one with panophthalmitis, where you removed the foreign body, even attached the retina, necrotic retina, and saved the eyeball integrity at least, if not vision. I think that was a good, very good case, a great feat, I must say, in saving the cosmesis of the patient. I think all of the cases also were very good. Any questions from anybody? Okay, we'll finish.